Thank you. Dr. Chowdhury doesn't need much of an introduction to people who have worked with him. He's the kind of person, in the morning before breakfast, he's opened up a public health institution. By afternoon, he's already got the funding, and by evening, it's grown big enough that he's actually got the government to take over it. And this is a true story. But two real things I want to share about Dr. Chowdhury in kind of reverse chronological order. One was, I called him one morning in the US and evening in Delhi, in India. And unusually for Dr. Chowdhury, he said, today I'm feeling a little tired. So I asked him what happened, and it turned out that he had a liver operation in the morning. He's a surgeon, he's a hepatologist. Then he traveled 4 hours to Birbhum, where he has a center. He did something, and then he traveled 4 hours back. So I said, why did you put in an 8-hour day just traveling back and forth after surgery in the morning? And it turned out that one of the informal providers he works with had run into a problem because one of the patients he'd been treating and referring wasn't doing really well. And Dr. Chowdhury took it upon himself, after doing a surgery for 6 hours in the morning, to travel across the state, meet with the person, meet with the patient, and make his way back. The second story comes before, which is, I've been working on healthcare in India for a while, and like most of these stories, one day Abhijit Banerjee calls me up, and he's like, are you in town? Can you come and have dinner with Dr. Chowdhury? I said, sure. And Dr. Chowdhury said, look, I run this institution called the Liver Foundation, and liver is its mission, but public health is the passion. And we have been training these informal providers. And Abhijit Banerjee and I had been working on healthcare for a while in India. And one of the things that we knew was, informal providers are everywhere in India. In other countries, they're called non-physician clinicians. In India, almost 70 to 80% of the primary care is actually provided by these, by informal providers, especially in rural areas. And then he told me something really interesting. He said, I don't know if the program is harming healthcare or improving it. I want you guys to evaluate it. I don't want you to tell me what you're doing. I don't want you to tell me whether it's going well or not. I want you to evaluate it without the people who are teaching or running the program even knowing that what you're going to evaluate. Right? That, for me, changed something in the way I was thinking about it, because this was the first time we actually met someone who's put his heart in the job, has skin in the game, and is still saying, I'm just interested in producing and understanding the knowledge. Right? So that's Dr. Chowdhury for you. And I wanted to start off with thinking about this idea of evaluation, which is so central to the JPAL mission, right? I mean, you have been one of the leading lights arguing for, rigorous evidence in healthcare, even when it's a difficult terrain, right? So tell us a little bit about, the evaluation we did, the Liver Foundation, informal providers, and what's been the whole journey. What's been your journey on this front over the last decade or so?
No, very exciting, Jishnu. Thank you. So I'll just, in this campus, I just remember this anecdote, and that would be interesting for people. And I really liked Ben's last word, that if your project is not, failing, then it's not sufficiently risky. So let me tell you that I landed up in this campus, and I think we met one evening in one of the restaurants, me, Abhijit and Jishnu, Abhijit Banerjee and Jishnu. So, the story was something like this. When we were training these informal providers out of a pure activistic outlook, because we had been feeling that, given the fact that Abhijit and Jishnu mentioned, they had been pointing out that India's 80% of primary care provision is met by these informal healthcare providers. But the health system, the mainstream healthcare system, looks down upon them, telling them as quacks, the word that has been mentioned here. The quacks means magic healers. So I used to argue that, why don't you call me a glorified quack? I'm dressed up with all the degrees that this country can provide. But I am also unregulated. if I do something, nobody is going to catch me, hold by the neck and tell, hey, you are wrong. That's the country called India or in a larger part of the world. So, okay, that's unregulated, but they are present. So either you route them out or you tell them what not to do and tell them what to do. So this was the basic provision of our work. We are training them. But at some point, the Indian Medical Association and a lot of other organizations started telling that, hey, Supreme Court of India has told that training the informal providers, training the so-called quacks is a crime. And this guy is doing a crime, he should be put behind the bars. So this was a rescue venture. And we were moving upstream and we were looking for somebody to come and tell us what wrong thing we are doing. So we are very clear that let's be very clear. I told my colleagues that let's face somebody. So who was that person? I was approaching a lot of people who does this evaluation. So meanwhile, one of my economist friend told me, and it's a very interesting story, that we are clinicians, we do clinical trials, we look for clinical trials. So that my economist friend told me that there is a guy who is a potential Nobel laureate who takes this clinical trial business and fascinating into social research. So why don't you know that? And I knew him, and I read his work. So then I approached Abhijit straightforward, wrote to him. So we are doing this venture. Why don't you salvage or destroy this by telling good and bad of it? So that's how it all started. And let me tell you that, and that's where, evaluations can really lead you to salvage also. And so we started doing this. And, Jishnu used to, start working at 5 o'clock in the morning, I still remember, and come back 6 p.m. from the fields. So we were doing the training program, and JPAL team was doing the rigorous evaluation, absolutely firewall. We didn't know the way they are doing it. They had standardized patients and everything, so they were guerrilla patients. They're going to the trained practitioners, and Jishnu was, he was in the fields and all. So it happened, it got published in Science. Okay, so now it was like a lot of upheavals in every circle. So, training the quacks, the quote-unquote, the term called quacks, who are untouchables, who are thought to be untouchables. Now it shows that training them really gives dividends. And at the same time, another part of their research was that they also evaluated the trained practitioners who keep on the people like me who have got all the degrees, so-called. So interestingly, it was found that the bad things that they keep on doing are only, glorification of the bad or amplification of the bad things that I keep on doing. And also, you can reduce the gap between the lack of practice between the two by giving the training. So, after that, as you know, it has been translated, and that was another part of the story, into a state policy. So, JPAL Liver Foundation's research, we came for salvage, approached to Abhijit Banerjee, JPAL, and everybody for telling us right or wrong. Finally, it has led to a tremendous snowballing of research around informal healthcare providers, along with in West Bengal, where I work with and we work. It's a state policy. After that, 2016, the paper was published. In 2017, the state's chief minister came down and told that this research has to be translated into state policy. So that rapid policy translation of research data is really something which is very exciting, and that has happened. And after that, we had been doing many, downstream works, like, we use the informal providers for tremendous amount of metabolic health outposts. We use them for COVID action. They were running COVID care facilities, and Jishnu has published on that also, that data. We are using them for tuberculosis case detection works, for leprosy defaulter retrieval program. And so that research, starting from that research, which was basically conceived of with an intent of knowing whether evaluation can lead to answer whether it is good and bad, has now led to a lot of downstream research, and there is tremendous amount of excitement around this. But I would like to tell that we had faced a lot of obstacles in that also, and it's not the story is not over yet. There are many people who keep on telling that this is morally incorrect to give a suboptimal. We tell them that you are not doctors, you are healthcare workers. So so this question of morally incorrectness, social incorrectness, and strategic incorrectness keeps on still plaguing our, further upscaling of the endeavor. So these are the flip side of the work that we are doing. We still are working with this. So it's really exciting story.
Wonderful. And we have videos of Abhijit Banerjee actually interviewing two of those, which we'll show in 2 minutes. Before that, just a couple of things. I do want to correct one thing, which is, the real person doing the work was Reshma Husam, who is a professor at Harvard Business School. And here, she's the one, I would get up at 5, wake her up, go back to sleep. So that was the true thing out there. But just one thing before we show the videos. This issue you raised, right, about there's research, there are the bureaucrats, there are the politicians, right? And, I remember I worked with Jean Drèze a long time back, and he has this book called Sense and Solidarity, and here's this view that research has to be what he calls action-oriented research. Right. And you're one of the people who really epitomizes this action-oriented, research. So tell us a little bit more about that. I mean, you have a foot in the politics, a foot with the bureaucrats, a foot with the researchers. How does it all come together? Does it not? What advice would you have for people working in this as we think about not only doing the research, but what impact it has or how it leads to a policy down the road?
Yeah, that's another, very interesting paradigm. Researchers, like when I work on a research project, I'm interested in data which has got a different language. Interestingly, when I work with the politicians or anybody works with the politicians, you have to keep in mind that they have got a very, very different way of looking at things. They are very opportunistic for sound reasons, and they only look at whether this information is going to translate into their tangible benefit, which is only getting votes, and nothing more than that in democracy, which you have to accept. And your way of convincing the politician has to be a very superficial, informal, coarse way of telling him or her that, hey, there is a program out here which if you get to your translate to your program is going to give you more votes and nothing more than that. And the bureaucrats have to be your friends. So the bureaucrats have to be catalysts. I think this job we had been doing for quite some time, and people who are engaged in research to policy translation job has to be, again, I'm giving some qualitative terminologies, have to be very polite, humble, assertive, confident himself or herself, but very strategic and suave and smart in getting the job done. All these elements have to be there. If you are very egocentric, if you think that, hey, I'm a great researcher, what I have done, why don't people understand that I am such a great person? And you have to agree to that. You are a fool. You are going to land up in disaster. And you have, you're on this side of the table, and you have to make your job. Your job is to lie low, be assertive, try to find out the right window, and put the thing into the politician's brain, whose time is short. He or she will give you 2 minutes time, and you have to hit it hard in his or her own language. Otherwise, you are through. So, this is an important part of social policy when we do as research to policy translation. And that's one of the ways we succeeded. The election was coming, and we told the minister that, hey, the informal providers are more than 1 million in India. And West Bengal is the first state that is going to do it. And so many people, they are great vote catchers. Why don't you give them something which nobody else had given? And the politicians' eyes were, beaming. So that's how it happened.
Yeah. And let's, so just to introduce you, these are, just to get a view on what these informal providers are like. Abhijit Banerjee recorded 2 videos with them, which I think would be wonderful to see at this point.
আমি স্যার মাধ্যমিক পরীক্ষা দিই 2003-এ, তারপর 4-5-5-এ আমি এইচএস দিই। এইচএস দেওয়ার পরে তখন আমার একটা সাবজেক্টে ব্যাক এসেছিল, আর ওইদিকে বাড়ির পরিস্থিতিও খারাপ ছিল, তা আর্থিক অবস্থা খুব খারাপ ছিল। এবার আমাদের কিছু কিছু রিলেটিভ আছে এই পেশার সঙ্গে যুক্ত, এবার তাদের মারফতে যে পড়াশোনা এদিকে বাবারও কষ্ট হয়ে যায় চাষবাস করে সংসার চালাতে, তো এই পেশার মধ্যে গেলে পরে হয়তো কিছু করতে পারবো, সেইভাবে এই পেশার মধ্যে ঢুকেছি। কয়েকজন ডাক্তারের কাছে আমি থেকেছি, কারোর কাছে 3 মাস, কারোর কাছে 6 মাস, কারোর কাছে 1 বছর, এইভাবে থেকে তার কম্পাউন্ডারি করেছি। এইভাবে সেটা দেখেছি, তাদের যে প্রেসক্রিপশন সেগুলি ফলো করেছি, কী ঔষধপত্র দেয় এইগুলি ফলো করেছি। এইভাবেই আস্তে আস্তে ধীরে 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 এই পেশার মধ্যেই চলে এসেছি আর কি।
তো এই যে যে ডাক্তারবাবুর কাছে আপনি এই প্রশিক্ষণ নিয়েছেন, তারা কি এমবিবিএস ডাক্তার ছিলেন, না তারাও নিজেই
না, কেউ এমবিবিএস ছিল না।
তারাও
না,
তাদের কি কোয়ালিফিকেশন?
তাদের কোয়ালিফিকেশান বলতে এই আমাদের মতন করেই আর কি, ওই কোয়াক ডাক্তার বা হাতুড়ি ডাক্তার, কিন্তু তাদের প্র্যাকটিস ভালো, পেশেন্ট হয় ভালো, চিকিৎসা দেয়, পেশেন্টও হয় ভালো, অনেক পেশেন্ট হয়। আর আমাদের গ্রামের মধ্যে অ্যাকচুয়ালি স্যার ওই এমবিবিএস ডাক্তার তো যায়ই না। তো এমবিবিএস ডাক্তারকে যদি কেউ ভিজিট দিয়েও দেখাতে যেতে হয়, মোটামুটি ধরুন 4 কিলোমিটার 5 কিলোমিটার দূরে গিয়ে তারপর দেখাতে হয়।
তো এই যে লিভার ফাউন্ডেশনের প্রশিক্ষণ কি শিখেছেন? একটা উদাহরণ দিন, যে জিনিসটা আপনারা কাজে লাগান, যে জিনিসটা শিখে আপনাদের কিছু লাভ হয়েছে।
লাভ হয়েছে বলতে, যেমন আমরা অ্যানাটমির কিছু জানতাম না, ফিজিওলজির কিছু জানতাম না, বা প্র্যাকটিস অফ মেডিসিন কি জানতাম না। লিভার ফাউন্ডেশনের ট্রেনিংটা নিয়ে আমরা অ্যানাটমিটা কিছুটা হলেও জেনেছি, এবং তারপরে থেকে আমাদের মানে আগে আমরা অনেক ভুলভাল করতাম,
এখনো আমাদের মধ্যে হ্যাঁ, এখনো স্যার আমাদের মধ্যে ভুল আছে, কিন্তু আমার যতদূর মনে হয় বা আমি যতটুকু প্র্যাকটিস করছি বুঝতে পারছি যে আগে যেটা করতাম তার থেকে ভুল এখন অনেকটা কম করি।
যেমন ধরুন একটা আইভি ইঞ্জেকশন হয়তো যদি কারোর করতে হয়, সেখানে একটা অ্যান্টিসেপটিক অ্যাসেপ্টিক প্রিকশন নিয়ে করতে হয়। এই যে অ্যান্টিসেপটিক অ্যাসেপ্টিক প্রিকশনটা কি, এটা আমরা আগে জানতাম না, দিয়ে দিতাম। কিন্তু এখান থেকে ট্রেনিং নেওয়ার পরে আমরা সেই অ্যান্টিসেপটিক অ্যাসেপ্টিক প্রিকশনটা শিখেছি, এবং ইঞ্জেকশন কোন কোন জায়গায় দিতে হয়, কোন মাসুলে দিতে হয়, এ সমস্ত মাসুলগুলোর নাম, ভেনের
কোন মাসেলটাই দিলে পেশেন্টের অসুবিধাটা কম হয়,
টোটাল বোনের নাম, এগুলো কিন্তু আমরা একটু রপ্তানি করতে পেরেছি। তারপরে স্যার আমরা যেটা আরেকটু মানে শিখতে পেরেছি, যেটা যেমন ডায়াগনোসিস, কারণ লিভার ফাউন্ডেশনে ক্লাস করে আমরা কিছু ডায়াগনোসিস শিখতে পেরেছি।
যেমন
যেমন আমাদের যে স্যার পড়াতেন উনি বলেছেন, যেমন হার্টের ব্যথা যদি হয়, কেমন তাহলে লেফট থ্রিকোয়ার্ডিয়াল রিজন পেন রেফার্স টু দ্য জ অ্যান্ড লেফট হ্যান্ড। যদি এইরকম লক্ষণ দেখো তাহলে তোমরা ভাববে ওটা কার্ডিয়াক পেন। কেমন তোমরা জাস্ট একটা সরবিটের একটা অ্যাসপিরিন দাও, দিয়ে কিন্তু ওই পেশেন্টের রেফার করে দাও। এই সমস্ত জিনিসগুলো কিন্তু আমরা এই ক্লাস করে এগুলো জানতে পেরেছি, যেটা আমরা আগে জানতাম না।
So just to, I mean, so in India they're called informal providers, but really the way to think about it is rather than a degree or a formal training, they have craft-based training, right? I mean, think about it as they have a long apprenticeship before they open up their new clinics. And in a lot of around the world, they're called non-physician clinicians. Some places formalize them, recognize them, others don't. In Kenya, where I worked, somebody told me they're the orphans of multiple donor programs through the years, who create a cadre of new professionals, and then they leave, and then these guys start their clinics. But one, couple more things that we have about 10 minutes left, but just wanted to ask you a couple of things. One is, what are you really excited about in healthcare? And I'm hoping you're going to say ChatGPT, but maybe not. I'm not going to prompt you in that direction, but tell us something about, you really think is happening in healthcare in low-income countries that you think will be very important in the next few years.
Jishnu, we have to be very clear that India is progressing very fast in many fronts, and that one of the fronts is healthcare. And so on one way, we are having the best of the facilities that the world have got right now for some people, not for everybody. So the access and equity is a plaguing discomfort for Indian healthcare. So what's happening is we are trying to Xerox Boston into Birbhum or Bombay, rather than making it contextually relevant. So while that is happening, India's rural folks have still to depend on these group of people. For whatever, some people call it, you are glorifying suboptimal caregiving to the country's regulators. and these people are unregulated. So two issues that keeps on telling us is you cannot do without getting into this group of people who were there when India got into independence in 1947. They had been there for over the 75 years of independence, and I believe they will be there because India's healthcare is taking a shape which is increasing its rural-urban divide. If that is going to happen, and you fail to eliminate this group of people in 75 years of independence, then why not take them into the fold and tell them what not to do, try to regulate them in some way, try to make them some amount of, give them some amount of science. They are craftsmen mostly without scientific knowledge. Give them some amount of scientific knowledge, and they're not really fools. One of your research, I keep on telling everybody, has shown that one of the greatest maladies of Indian healthcare system is tremendous no-do gap. In Jishnu's work in health policy and planning at some point has shown. So while I have got the no-do gap, they have got a diminished no-do gap. If they are hungry for knowledge, if you give them some knowledge, they translate that into a better action. So what I'm excited, again, you mentioned about ChatGPT, is I'm still excited that if we can give them some, IT-based tools. Everybody have got Android or phones right now. So we are planning some work. In fact, Abhijit could have been excited to tell this today, wherein we are trying to give them decision support systems based on AI tools and all in their phones and all, and try to see whether that improves their performance, that gives them a way to regulate them also. It's not very easy. Like, your conceptions often translate into tangible outcomes, but that's one of the ways. The other thing that can happen is, government or academia, both together, has to be very transparent in approaching them. Somehow, we maintain a strategically ambivalent position about them whenever any dialogue comes. We know that they exist, but whenever at the policy level, any discussion about the informal providers takes place, we say, they are bad, they are bad, they are bad. They are untouchables. So we have to be very clear, and we need to mount more and more evidence like this. The research that we did and the researchers after the initial research that we with JPL and we are trying to carry forth this, opened up is at least, this whispering thing has come now to forefront, surface. Now people knows that with Abhijit Banerjee's and our Abhijit Square people tells research, at least, these are the people who can be, turned into, in fact, we took to planning commission level also at some point. But again, it's not very easy to close door. We have to keep on hounding at the doors of the policymakers with evidence. Without evidence, we cannot happen. So AI tools are going to be interesting. We are, in fact, conceiving of work with this. We are looking for funding as well as technical support on this.
Right.
So these are some of the future ideas that we are playing with.
I mean, that sounds great. I mean, AI is interesting because around 2000, there was a lot of movement around mHealth and kind of thinking about, these tools, these digital health tools. And there are a bunch of evaluations in India and other low-income countries that didn't do very well. And I think we got burnt. I think we got very badly burnt thinking that these things were not going to work. But the last 20 years, there's been such fundamental change in the way people are accessing these systems in smartphones in every pocket that I think resurrecting and rethinking, how can this help us? I think it's at the right time, and super excited to hear that you'll be doing that. Just cognizance of time, a couple of things. I mean, I want you to, one last question. I wanted to give advice or your thoughts on, there are lots of young people now working on, JPAL has now grown enormously, lots of young people, affiliates, researchers. What's your advice going to be? And in a specific way, Abhijit, which is one thing that's really always struck me about health, and particularly during COVID, is, well, it's the place where RCTs were invented in a way, thinking about anthrax, thinking about vaccines. And it's always been the case that if you look at vaccines or clinical treatments, we are happy to delay implementation till we have a rigorous, evidence. But then when we think about policy in healthcare, and this became so evident during COVID, where were the evaluations? Where were the RCTs, right? And it's really worth thinking about. I mean, so for example, I really feel that we missed a chance to say, should schools remain open during COVID, right?
Absolutely.
Was that a mistake? Should there have been an evaluation, right? Early on when we thought about this. So as you provide this advice to younger people on how to navigate this, also thinking a little bit about how do we take the fact that doctors are very familiar with RCTs in clinical medicine, in vaccines, and say, hey, why aren't we doing more of this for policy? Why aren't we doing evaluations of regulatory things? Why aren't we doing evaluations of how to price in insurance? Why aren't we doing evaluations of whether schools should be locked down during a pandemic, right? What's going to be your motivational pitch in a way for a young researcher who's really trying to make a difference in the world?
Okay, so it's a very broad question, but I would like to, this is very important to discuss also. COVID, as you mentioned, had been a closed window for all of us. We don't want to discuss right now anything of COVID and keep on talking about pandemic preparedness for another pandemic. But if you ask somebody that, hey, you prescribed hydroxychloroquine for COVID, you prescribed doxycycline for COVID, based on what evidence? No evidence. Policies, unfortunately, in healthcare often come out of great people's minds and then put to politicians, insecure politicians' mindsets, and then translated into action. That's precisely what happened during COVID times. So we need to generate evidence, and for generating evidence, that's the only way of getting things changed. And for generating evidence, I would love to look at more intimate crosstalk between social scientists and medical professionals. That at least in our part of the country, that does not happen. Somewhere there is a large part of the world, like the clinicians think that whatever is written in books and whatever I think in a very reductionist window is what should happen, and the social scientists have got a different way of looking at. So that should be bridged, one. Second is, we need to look at more of social scientists who would be inclined to do more legwork rather than desk work. I think I could make home what I mean. Unfortunately, everybody is interested in looking at metadata, analyzing those metadata, coming out or pumping out papers, rather than generating primary evidence, which is what RCT, if you want to do RCT community engagement, then you have to go to policy, you have to go to communities. So that's very important. Third is, implications of policies that have taken place have to be tested well now. Now there are many, in every health systems and everywhere, there are many policies. Like say India is taking an very interesting matrix in healthcare. Tremendous pace of progress of privatization is taking place. Government somehow has decided to go to demise as long as their participation is concerned, somehow. And that's my perception. I may be right or wrong, but that's precisely, and privatization is taking place. And let me tell you that the question of unregulated healthcare, if I tell that the quacks are unregulated, then what amount of regulation is taking place in the private healthcare sector? I mean, as a health researcher, I would instigate you to undertake research, not only your students, to undertake research that looks into the quality and regulation perspective in the burgeoning private sector. India have got a tremendous spirally increasing participation of the private sector into the medical education scenario, health education scenario. So whoever is becoming rich through, say, cement business or coal business or whatever business is pumping money into healthcare sector, because healthcare sector, having a medical college gives a social dignity and social prestige, which does not come, through a coal business or a cement business or some other business. So, the culture of coal sector, cement sector, I'm not again demeaning their practice, is also getting pumped into here. So money only as the outcome is becoming the language of the upcoming medical education, health education in India. You know, these are, health insurance is coming in a big way. And you know, health insurance, outcomes of health insurance, we have not evaluated. It's like, you know, the India, government of India has got a health insurance program. Many states have got their own programs, and we are yet to evaluate what's happening in them. So for a futuristic health economist or social researcher, there are many research questions which has to be answered by raising important, interesting questions at the community level, readiness to go generate primary data, spending time in the community the way I saw you doing. I mean, again, I'm mentioning that I used to get enthused by seeing your zeal. So that's present in many. We need to, our job, and that's why we are together here. JPAL's role would be to provide a backdrop for doing that. So there are fascinating places to work. Yeah.
Great. Well, we should be finishing up. Just, you know, one final anecdote. I mean, Asim Khwaja sitting there and I were among Abhijit's earliest students. And both of us spent a year in the field. So, you know, halfway through our PhD, Asim was like, I'm vanishing to the mountains of Pakistan to do to work on community development. I was like, I'm vanishing to India to set up a clinic in a remote village. I think that, you know, that was, Abhijit looked at us like we were mad. He was probably right to do so, but he was also exceedingly encouraging. I mean, he said, look, you know, we need to find out what's happening. You need to, you know, we need to see how this is going. And it's so wonderful to see now it's de rigueur, right? For a development economist to spend a lot of time in the field, trying to think about their projects, trying to think about what's happening. The only thing, you know, we're in Boston, so I can't help but end with a car talk reference for those of you who are still old enough. My basic learning from setting up a clinic in a village for a year with my brother was don't do medicine like my brother. So with that, you know,
Just a final,
Dr. Chowdhury, final words for you.
Yeah,
and,
so I was just wondering when I discussed with the informal providers we train that, hey, MIT is going to have a symposium where one of the discussions is going to be informal providers. They were, you know, up with eyes, hey, we are going to be discussed. Unfortunately, that's what happens. You know, they are full of energy. They are community engaged. Whatever they do wrong things, but they don't do wrong things in a way that's, you know, that's known to be money-based and all. They take money, but they keep on doing. So if you ask me as a professor of liver disease, I find more pleasure in training the so-called quacks, and I would love to keep on training them with Abhijit Banerjee doing the evaluation. Thank you.
wonderful, Dr. Chowdhury. Yes.